Hi there to everybody. Thanks very much for joining us for our webinar today on World Down Syndrome Day. I think we'll get started if everybody's okay with that. So first of all, thanks for joining us. And as I'm sure you're all aware, it's World Down Syndrome Day today, and we're delighted to host this webinar, Multidisciplinary Care for Children with Down Syndrome Arthritis. And I suppose just a few short slides at the start, just to give you a little bit of information about Arthritis Ireland, and then I'll introduce you to our speakers on the day who very kindly have joined us, and just a few little things about housekeeping and our Q&A session as well. So, for those of you who aren't familiar with this, Arthritis Ireland is the national charity and patient organisation for those living with arthritis in Ireland. We deliver support, training, education and information. Our free national helpline is open from Monday to Friday from 10 to 4 p.m. for support, information and to register for programmes. And our helpline number is 0818 252 846. We have a lot of information about our resources. We have a lot of resources online. We have booklets and we have lots of videos. We have a YouTube channel, and that can all be accessed through arthritisireland.ie. So please feel free to use the website for information and help and support. Just a little bit about our involvement in research for Down syndrome in the past. We've been involved with Down syndrome arthritis research for some time. The organisation, alongside Down Syndrome Ireland and the National Children's Research Centre, supported a 4-year groundbreaking study into Down syndrome arthritis that was undertaken by Dr. Charlene Foley under the supervision of Dr. Orla, Kileen, who's joining us today, as well as Professor Ursula Fearon and Professor Jerry Wilson. And that research helped to raise awareness about the condition, Down syndrome arthritis, and led to the establishment of national musculoskeletal screening to identify undiagnosed cases of DA, and also to establish if it was being missed. And then following that awareness campaign, then children with Down syndrome were invited to attend assessment clinics, and where there was evidence of joint problems, they were followed up by the National Centre for Paediatric Rheumatology. So we were delighted to be involved with that research, which was really groundbreaking at the time. And currently at the moment, we have our Arthritis Ireland Research Coalition Biobank. This was established by Rheumatologists in Ireland to support much needed research into arthritis. And basically this is, there's so much work to be done in this area, and it's ongoing. Children's Health Ireland is participating. Blood and body tissue biosamples are absolutely vital, and they're collected through this process from people living with various types of arthritis and related conditions. So that's very exciting work that's underway at the moment. So just a little bit then about our agenda today. So we're going to start off, Dr. Orla Kileen is going to kick off. She's going to talk about the transition from child to adult rheumatology services. Then Cathy White is going to talk about occupational therapy for Down syndrome associated arthritis, followed by Rachel Ruddy, who'll talk about physiotherapy. So we're delighted to have them here today, and we really appreciate them giving their time. Also, I'm going to hand over to Aisling McNiff, who is here to represent Down with Arthritis, the parent support group. So she's going to say a few words at the start as well. Just in terms of housekeeping and Q&A, everybody's, except for the presenter and speakers, are on mute and cameras are off. If you have a question, please put it into the Q&A function in Zoom. And we've allocated 30 minutes at the end for Q&A, and we will take as many questions as we possibly can. And we'll direct the question to the relevant speaker. So we hope you enjoy the webinar, and we hope you're able to get a lot of information from it today. It will be recorded, and you will be sent a link to the webinar tomorrow, but it'll also be available to you to view on our YouTube channel as well. So thank you very much, and I'm going to hand you over to Aisling now, who has a few words to say on behalf of Downs with Arthritis.
Good afternoon, everyone, on this lovely World Down Syndrome Day. My name is Aisling, and I co-founded our support and advocacy group Down with Arthritis with fellow mum of a child with Down syndrome, Elaine Keogh, over 5 years ago. My own son, Jack, has been under the care of the rheumatology team since he was a year old. He's now 18. And in the beginning, the team was really just Orla, Kileen. So times have moved on and changed. Initially, our advocacy and support group, Down with Arthritis, was very small, and it really started off with only a couple of us. And then as the research went on, more and more children started getting a diagnosis or having symptoms of DA. We are here to support one another, and every day we learn new things. We now have over 300 parents of children and adults with DS in our group. We have a small admin team in which Padraig Begley plays a big part, and thank you to Padraig for helping organise this today. He's unable to be here, unfortunately, because his daughter Eileen has her confirmation. And I hope they have a wonderful day. Thanks to Padraig and for all he does for our group. And Ellen Lacey created a wonderful video raising awareness of DA, which we will see at the end of the webinar. And it would be remiss of me to forget Susan Quinn, who named our group Down with Arthritis. I'm delighted to be here today, and we thank Arthritis Ireland and especially Tara and Kileen for hosting this webinar. And of course, Dr. Orla Kileen, Paediatric Rheumatologist, and Occupational Therapist Cathy White, and Physiotherapist Rachel Ruddy, all who have made time in their hectic schedules to come here and talk to us and share with us how much they know and can advise us about Down syndrome associated arthritis and the management of it. So thank you.
Thank you very much, Aisling. Orla, I'll hand over to you now if you're ready to go.
I think we are. Are we good there, Tara? No.
Yeah,
okay,
good. Thanks.
Good afternoon, everybody, and thank you very much, Tara and the team in Arthritis Ireland, and of course, Aisling and Padraig with Down with Arthritis for inviting me and the team here to speak today. So we're delighted to get this opportunity, and particularly on such a special day, World Down Syndrome Day. And when we were asked to do this, we kind of felt that we'd put the question back out to yourselves, what would you like to know? And transition was probably the most favoured topic, and hence why we've combined the talk today about transition and DA, or Down syndrome arthritis. So I'm actually delighted to get to talk about probably my two favourite topics. Obviously, DA is my big area of research, but also transition, which is actually incorporated into my own job spec, in the sense that when I came back 18 years ago from the UK, point 3 of my job was to actually set up transition services, and I run a yard clinic with Professor Malloy in St Vincent's University Hospital, which you do every second week. So I'm delighted today to talk about both topics, both of which I would feel very passionately about. But I thought we'd start today just telling you a little bit about transition, and this is kind of a buzzword that you're hearing a lot about out in, I suppose, the public forum and places at the moment. But there's a variety of different definitions. One of my favourite one, however, is that the one proposed by the American Society of Adolescent Medicine quite a few years ago, and it describes transition as being a multifaceted, active process that attends to the medical, psychosocial, and education and vocational needs of adolescents as they move from child to adult-centred care. But it's not just in healthcare that transition applies to. In fact, our young people are transitioning once they hit their adolescent years, not just in healthcare if they've got a chronic illness, but obviously in their own family setting. They're moving from a very sheltered, I suppose, unit with their parents and their siblings, if they have them, into, I suppose, a life of independent living and self-advocacy. And at school, they're moving from, you know, middle school, high school, secondary school, into either the work place or third level education, or into training. And then obviously what applies, we mean to transition, is the healthcare process, moving from the paediatric setting into the adult setting if required. What are the aims of the transition? Well, we all have good aims, but it's trying to attain them is the issue. But the main idea is to provide coordinated, seamless, uninterrupted healthcare, and it should be age appropriate, developmentally appropriate, and comprehensive. And there are 3 core principles that we try to apply. And it's about promoting skills in communication, decision-making, assertiveness, and self-care. And it's to enhance their sense of self-control, self-advocacy, and independence in healthcare. So timing of transition, well, we say it's a stage, not particularly an age. There's not one set criteria that we have to follow. It's a number of issues. It's multifaceted, as I said in the beginning. And it is very much, I suppose, unique to that young person. So it's not as though they suddenly hit 13 and you have to start transition. It very much centers around where that patient is in their healthcare, where they are in terms of their medical status. Sometimes if a patient's having a very bad flare, the whole process transition can be difficult to take on board as well. So it's very much relevant to how that patient is getting on. And remember, two 13-year-olds are very different. You can sometimes have a very mature 13-year-old and a very immature 16-year-old. So we don't fixate just on chronological age. It's very much on a combination of different issues. But some of those factors include, the fact that the adolescent, a young person, needs to be actually ready themselves. And of course, there's no point starting transition if you haven't got identified somebody in the adult setting that you're going to be able to transition your patient to. So many factors play into this. As we say, it's a stage, not an age. So what does the research tell us? Are we any good at doing it? Well, there's lots and lots of reports out there to say that across the world and in Europe-wide, we're not actually very good at it. We have good intentions, but in reality and on the ground, it isn't really happening in a lot of places. A lot of people describe the experience as more of a transfer rather than a transition, and they describe it as being disjointed and more of a once-off process rather than a continuous process over a number of years. And what happens when we don't have good transition? Well, we know that potentially can affect the health long care of our patients and young people, and sadly can lead to disengagement from services. And this is something I do see even on the other side when I work over in Vincent's Hospital. In the paediatric setting, patients don't turn up, or if they're on medication, often they may get a call from the team because we work so closely. But in the adult world, it's a larger setting, and sometimes there isn't the same engagement with services, and people can fall off, not attend for clinics, and then turn up months, if not years later, in I suppose, a crisis presenting through ED. So we know that planning and transition can lead to long-term poor outcomes long-term. So what else do we know? We also know that if you don't have a transition process or you have a very poor one, it can actually lead to increased problems in terms of lifespan and other illnesses. There's lower satisfaction for families and for patients. They can get lost to follow-up. They may not be on board or taking the medication, or non-adherence can be a big problem, and outcomes can be worse. And at the bottom line, it costs much more to the state. So we know there's increased healthcare costs when we don't transition well. So many of you will say to yourself, this is a no-brainer. Why aren't we doing it as well as we could? So it's all about minding the gap. And that, of course, was one of the titles, or the components of the title of my talk today. It's all about don't fall down in that gap as you transition from children's services or pediatric services into the adult setting. But sadly, it happens too often, particularly in chronic disease. I want to bring your attention to this really important document, Bridging the Gap. And I was actually working in the UK when this was published. And it's a really groundbreaking document that was commissioned by the Royal College of Paediatrics and Child Health. And it was looking at chronic disease. So I'm talking across not just rheumatology, I'm talking about children with cystic fibrosis, children with disability, children with epilepsy who needed ongoing adult care. And this is a super document that made some recommendations with a huge input from our own Janet McDonough, who was based in Birmingham at the time, but originally from Ireland, who has a huge interest and still continues to publish in transition care. However, even over 10 years later, the Quality Care Commission, despite that document being groundbreaking and a framework for services, transition really didn't get established in as many places as we'd hoped across Europe and the UK. And families do feel, I suppose, very strong about this issue, and rightly so. And some of the quotes you can see here, particularly from one dad: everyone seems to want to do the right thing, but there seems to be a missing link. No one seems to work together. Mom felt that from the pond, you were picked up and you're put into the sea and you're swimming, basically. And from the patient himself, described as feeling left in a place where I don't know where to go anymore. It makes me feel insecure. The GP doesn't want to see me. They don't want to take responsibility and want me to go to the local A&E or ED. They don't have the experience in pediatric training. So kind of a feeling of being, I suppose, lost and falling through that gap, definitely from that patient. So The Royal College of Paediatric and Child Health themselves, who commissioned the document even 10 years later, acknowledged the fact that things weren't being done well. And they felt that patients were passive recipients and accepted complications as inevitable. Transition across the board in all healthcare at the time in the UK was poorly documented, and there were unclear and non-existent processes with confusion over who takes responsibility, whose role is what. There was challenges, and they weren't just financial, but they were also clinical. And although there was goodwill and there was I suppose, there was enthusiasm across many clinical teams, a lot of people did lack insight into what changes were required and what planning was required. So it's not just healthcare and systems that's a big change for us. It's a huge change actually for the family as well. And I suppose we described going through transition as a big change for the family in particular. We're very much in paediatrics working a triangular model where we've got the doctor, the patient, and the parent. And we often may have the grandparents in there and siblings. So it can be a very busy place and a very busy clinic room. And obviously when you have presented at 1, even 2, 3 years of age, which often is the commonest age we see arthritis present in children, you have always had your parents there and you've always had your extended family with you, and you may be coming to paediatrics for 15 years or even 17, 18 years, and suddenly you're going into the adult setting where very much they work in what we call that linear fashion. So you've got the doctor and patient, and this can be very hard for a young person and a teenager, but it can be even more hard for parents, which I suppose in a situation where they've always been the speaker and the advocate for their child. So it can take a huge, I suppose, adjustment period for families when they see the change in how consultation works in the adult world. So before I talk to you about transition and juvenile arthritis, or JIA and DA, I just want to bring to your attention what we know about transition and chronic disease. So we know that actually probably between 10 and 20%, so even up to a fifth of children under 18 have a chronic illness in developed societies. And what are the stats in Ireland? We're looking at the Department of Health figures from 2010. They suggested up to 23, almost 24% of 16 to 24-year-olds report chronic illness or disease. What we do know is that the number of children, adolescents, and young people with chronic healthcare needs is increasing. And that's on a trajectory, and very much so continue to rise, of course, with our expanding population. As we all know, population in Ireland has expanded significantly over the last 2 decades. And in general, chronic disease is associated with lower education attainment and higher school absence, so school absenteeism. There's widespread evidence that children with a chronic illness are at increased risk of emotional and behavioural problems. They're at high risk of bullying at school in particular, and they're actually more likely to engage than healthy peers in risky behaviours. Now, we know our teenagers will engage in risky behaviours, and that's quite almost to be expected with adolescents, but even more so, surprising for some, that it happens with people with chronic disease. So what do we know about the transition in rheumatology? Well, like I suppose for many conditions, sometimes what actually happens is that patients' diagnoses get relabeled. So what we would find, one thing in particular, is that JIA, or juvenile idiopathic arthritis, of which there is actually 7 types, when our patients get into the adult setting, they often lose that diagnosis or that label and get reclassified as rheumatoid arthritis. Now, many of you will know from, I suppose, hearing us talk about arthritis in the past, that actually rheumatoid is quite rare in children. It only accounts for 5% of all the types of arthritis we see. But what happens is they get into the adult setting, and because rheumatoid is such a common form of arthritis in the adult world, our patients get relabeled, even though they may have had the condition since they were 2 or 3 years of age. But also what actually, there can be, I suppose, misconceptions that often understanding in the adult world that juvenile arthritis can burn out and it doesn't affect people going into adulthood. That's one of our problems. But significantly, the other thing is too that even a quarter, and then sometimes we would find in recent times up to a third of our patients present for the very first time during their teenage years. And you can imagine this is a very difficult time. All of us have been teenagers before, and usually when I ask a crowd, probably about 95% of us would never like to go back to our adolescent years. It's a difficult time. We'd all gladly go back to our 20s when we were probably enjoying things young, free and single, but going back to adolescence would be a challenge. And for all of us, it's a time that we all have to go through, but it can be a time of, I suppose, a lot of getting to identifying yourself, but also establishing yourself in your career, in your educational side of things. So it can be a challenging time in everyone's life. But significantly, probably up to 40 to 70% of patients with juvenile arthritis will still have ongoing active disease. That means arthritis still as adults. So there's a huge requirement for us to be able to engage with our adult colleagues so that we know there's a seamless pathway there for patients to go on into the adult healthcare setting. So Down syndrome associated arthritis, well, what do we know about DA and transition? And I suppose to be straight up, very little, because of many of you know about the research we've been doing here now for over the last 10 to 15 years, we would have the biggest cohort and patient number group worldwide, but we don't have that long-term data because really our patients are only really going on into the adult setting in the last few years. So Tara alluded to some of our original research that we did, where we looked at what was the potential incidence of arthritis and Down syndrome. And up to that point, arthritis was mentioned, and it used to be called arthropathy of Down syndrome. And we've actually retermed that name, and I'll explain why in a few minutes. But before we did this research, usually the most commonest thing that people thought about when they thought about children with Down syndrome and musculoskeletal issues was things like neck instability or C-spine instability or flat feet or twist in their spine. But in fact, what we found was that arthritis was the commonest musculoskeletal problem, and it occurred in 7% of our patients, which was much, much higher than what even the small case reports had reported prior to our study. So our findings showed that it was 20 times more common than juvenile arthritis, and it was double as common as what previous reports had suggested. We also found too in our study that the time to diagnosis was significantly delayed more than the group with new juvenile arthritis, and that didn't surprise us. We also found too that the route to diagnosis obviously was different, with most patients with juvenile arthritis coming through the normal route of our pediatric colleagues, our general practitioners, or orthopedics, where most of the patients, or the new patients with DA diagnosed during this time period, came through our research. Clinically, we found too that it was a much more aggressive type of arthritis. And what I mean by that is that on X-ray, we found lots of more changes and damage. So erosions in particular were significantly more common in the group with Down syndrome associated arthritis. We also had problems with soft tissue swelling and some narrowing at the joint space. So all the classical complications that we can see with any form of arthritis were commoner in the DA group than it was in the juvenile arthritis group. This led us to think, oh, is this the same condition? Because all the patients that I had seen in the past prior to my study, having trained in the UK, were always called juvenile arthritis. So any child with Down syndrome was always labeled as having juvenile arthritis. So this got myself and the team here thinking, saying, well, could it actually be a distinct disease from JIA? Are we talking about something completely different? So hence we delved a bit further in, and then in collaboration, not only with UCD, but taking on Professor Ursula Ferron's team and her laboratory and her support and collaboration from Trinity, we did some further work. And we delved into the immunology and looked at the cells that are involved in fighting inflammation in the body. We also looked at some histology, which means some biopsies of the lining of the joint, or synovial biopsies. And hence, as a result of that study, we felt that Down arthropathy, or the old term for arthritis and Down syndrome, was really not really reflecting what we were dealing with. This is an aggressive form of arthritis that can cause more damage. And we were able to show that both at the cell level. We could see what we call T-cell polyfunctionality. In the biopsies, we saw increased blood flow and cells coming to the lining of the joint. So it was telling us it was a more aggressive type. And clinically, we felt this was a much more aggressive type for arthritis than juvenile arthritis. And hence we coined the term in some of our papers around 2019, where we rephrased this condition and called it Down syndrome associated arthritis, or DA for short. So the other caveat to this condition is that we felt that we need to highlight that the symptoms of this condition can often be much more difficult to identify than juvenile arthritis. The typical symptoms of pain, early morning stiffness, or swelling that we would see in a patient with JIA may be absent or significantly reduced. And sometimes the findings can be very obvious or very large, but sometimes they can be subtle and definitely a lot more challenging. And we often would address our consultation with our patients and their family with Down syndrome in a slightly different way. We'd be much more interested in hearing about their stamina or the patient's exercise tolerance and a change. And the important thing about looking after somebody with DA is trending the pattern, because you can't assess everything in one consultation. Getting to know that patient over time gives us a much better insight into how they're doing. So we may look for clues and cues where sometimes our patients would easily have walked to school 10 to 15 minutes. And now parents will tell us over the last 6 months, they have to stop 3 or 4 times. So it's a change. So we're always looking for a change or a loss in stamina. And sometimes it can be a change in behavior. We've had some patients and young people with Down syndrome who would always been in good form. And suddenly there's been a change, being quite upset or for having disturbed sleep, patterns like that. So they could be potentially be indicators of arthritis, not always, but potentially. But really follow-up is crucial with this condition. So one of the big problems we knew about a delay in diagnosis was much, obviously, if you remember back to my original slides, it was a significant delay in diagnosis compared to JIA. So we knew that our patients with DA were up against it in a lot more way, as opposed to a young person presenting with JIA. And some of the challenges were definitely a lack of awareness of the condition. And you as parents know that there isn't a huge awareness about this condition out there in the general public. Now, I will say it is much better than what it was, and we are very fortunate in Ireland, but compared to other countries worldwide, there really is a huge lack of awareness, and obviously something we want to improve over time. Our patients with Down syndrome often will not express pain or might have a delayed response. It's not that they don't feel pain, it's that their expression of pain may be impaired. And sometimes there has been studies to show that children with Down syndrome have a delayed response. Verbal skills can be a big issue. We know that some children with Down syndrome may have coexistent autism or be non-verbal. So vocalizing or identifying pain can be very difficult for parents, but also very difficult for us as clinicians. Even in our own study, 91% of children in that original study had poor language skills, 15% were on the autistic spectrum disorder. The other thing is too that there can be a gradual loss of function over time. So sometimes it can be so subtle that it's only when you look back over 4 years, you notice that your child is requiring an aid like a wheelchair. So there are always questions we need to ask. Why is this patient now requiring a wheelchair when they didn't need one before? Or is there a regression or a change? There may be coexistent behavioral problems that makes it more difficult to identify if the patient is in pain or if they're having symptoms. And also, we know that some of our children can have significant intellectual disability and delay in motor milestones. So these are all challenges and hurdles up against our patients with DS. And so one of the most significant things is that nearly every child with Down syndrome is quite flexible or hypermobile. And a lot of times, because they're so extra bendy or extra flexible, a loss of range of movement as a result of arthritis mightn't be picked up because they are so still in the bendy range. And also, it can be difficult sometimes to examine a child. They may not want to cooperate, and that can go for children whether they have Down syndrome or not. Sometimes children just do not want to cooperate. So you have to take your chance when you can. And often you will have to sometimes even get down on the floor to examine the children, and so be it if it needs to be done. Back to transition and adolescence, so we're saying that's often a difficult time. We know there's lots of things up against our children with JIA. They're fighting with becoming independent, fitting in with their peers. They're fighting sometimes with new issues in their mental health. There's a time of risk-taking behavior. And then can you imagine if you've got a chronic illness such as JIA, on top of that, you've got to take medications, you want to feel the same as your friends, there can be restrictions on things like alcohol, there may be coexisting fatigue, they're worried about their growth, they're worried how they look. So it can be a very difficult time for somebody, particularly with a chronic illness such as juvenile arthritis going through those teenage years. What are the hurdles to a successful transition process? There's many of them. They can be the young person themselves. They may not want to go through transition. The parents too may not want the process to start. There may be a lack of adult professionals on the other side. The paediatric health profession may not be familiar. There can be a lack of services, training, finance, time and money. So not surprising, all the standard things do apply. But what about Down syndrome associated arthritis and transition? Well, as I said, we don't really know, but I can tell you there's even more hurdles. And I suppose what I'm saying is that there's a few unique things that are greater barriers for children with DA than even JIA. In particular, they can often be coexistent medical conditions or comorbidities. So we know some of our children with Down syndrome can also have other medical problems such as a low thyroid or celiac disease. They may have problems with other issues, cardiac issues. They may have other issues requiring them to go to other services like the gastroenterologist or the hematologist. So they often will have more more medical conditions than a child with JIA. There's even a greater lack of awareness about this condition compared to juvenile arthritis. There's definitely a lack of adults, clinicians who are aware of this condition, even more so than juvenile arthritis. And one of the big problems is that children with Down syndrome, whether they require a medical physician in the adult world, it can be difficult to identify one person to take charge and coordinate their care. So many of you will be familiar with a community pediatrician or a general pediatrician. It's often very difficult to find the equivalent such person on the adult side, or they don't particularly really exist. Also, I would be concerned that, is there a lower acceptance of good outcomes, or I'm worried that in time that, people will say, well, we don't expect this child or a person with Down syndrome to be, I suppose, playing sport at 40, 50 years of age. So is our expectations in the adult world less than what it is in the pediatric setting? I don't know. I'm just throwing that out there, but that's potentially one obstacle or barrier for patients with DA. And also then there's the issue of medication availability and routes of administration. Sometimes medications are only available sub-cost, and there's no option to have it as an infusion that we may have in the pediatric setting. Merits and pitfalls. Well, sometimes with transition, and this is not just for juvenile arthritis or DA, this is in general, there's sometimes I suppose a concept that, well, we cause the problems, we should fix it. And on the adult side, there may be a lack of engagement because the adult services may not look into growth, into development, and they may not take into consideration the full family concerns. They very much see it as a linear pattern that they engage with the patient only. But remember, we should never just assume that young people are just small adults, or adults are large children. Keys to success, the bottom line is one model of transition doesn't fit everybody. I would advise to start early, get care plans in place, always engage the GP when you're working around transition. The transition process should be patient-centered. It's important to have good administration support and engagement. So engaging both the family, the clinician and the team on the pediatric side, as well as on the adult side. But overall, the two probably biggest, I suppose, reasons for a failure of a good transition process is finance and lack of planning. And they're the two things that come back to haunt us all the time. This is not just for the Western world. This would apply to North America and our colleagues, particularly in Australia and Asia. I mentioned about some models, not one type fits all, there's different types. Some people would consider transitioning as just a transfer. There's often a joint transition with adult and pediatric services, and that's really the model that I follow with my clinic with Professor Malloy and Vincent. And this is a model very much what the UK would follow also. In some places, and sometimes even in the States, there can be lifelong follow-up with pediatrics, and it wouldn't be unusual for somebody to be 25 or 30 still attending pediatrics. It can be a generic transition team. So you might have an adolescent team where everybody, whether they have inflammatory bowel disease or they have something like epilepsy or cystic fibrosis, that they just go to one team who looks after all the specialties. So there's different models out there. But I suppose I just want to highlight quickly, this slide just showing that, in the pediatric side, it can be very busy because you've got all these different people, often even in the consultation room. And over time, as the transition process starts, it thins out. And there's often, we describe stages 2, 3, and 4, and this can be applied to children as young as 11 to 13, 14 to 15, 15 to 17, and then when they go into the older age, it goes into that more linear model that I described earlier with the young person, plus or minus engagement with the parent and the adult services. I've talked about models and types of transition and what's, hurdles, but is there good research to say that it does work? Well, there actually is. And a lot of the research is done by, as I said, to Janet McDonough and her team, but also very much worldwide, particularly in pediatric rheumatology. So JIA, I suppose, has always been at the forefront of transition across disease types and disease spectrums. But we now have nice evidence showing that transition and a good transition process improves disease control and better quality of life. It improves patient and parent satisfaction, and it improves clinical follow-up and attendance. and overall better healthcare and readiness to engage in their vocation and work. Briefly mentioning to you our yard clinic in Vincent's. This is our young adolescent clinic for those rheumatic diseases. And I established this with the late Professor Barry Breslin about 18 years ago. And our young patients from about 15, 16, 17 from here, if they're in the Dublin area, usually move on to this clinic with me. And this is attended by Derek, who many of you know here as our AMP, and an AMP on the Vincent side, Patricia Minnick. And our young people stay in this clinic till about 2021. And then if they need adult services, they move on into the adult clinic, but they're kept separate and they don't get relabeled as rheumatoid or other disease types. So it's a very nice clinic and it's a gradual process, which we do twice a month. That's some of the transition work that we do time points, just reviewing, do they understand? Have they met the team? Have they asked questions? Just give you an idea what we do at the clinic. Finally, before I wrap up, I want to just mention really briefly too, this is a framework document that I was involved in pre-COVID, and we were asked to chair bringing in as many as our paediatricians and adult colleagues who work in chronic disease. And unfortunately with COVID, it never got launched, although it was almost at that time point. But this is a commissioned document that we did to the Royal College of Physicians here in Ireland in Kildare Street. And I'm glad to say that my colleague, Ciara Martin, who's now working with the HSE in the clinical programs, has been asked to take this document on and develop it into a framework. So this is a really nice piece of work that we've done, and it's going to be launched this year, and it's transition across the board in Ireland from paediatric adult services. So this is looking at lots of specialties, but it's the beauty of this one, it's across specialties. So it's for children with disability, children with mental health issues that are chronic, children with inflammatory conditions like arthritis or inflammatory bowel disease. So there's 9 standards and they can be applied to all children transitioning. And I think this would be a nice piece of work that we can base transition on, and recommendations to our government, and that we can lobby for more funding and dedicated transition clinics. So finally, I suppose the things that I want to highlight, that if we're transitioning our young people with Down syndrome associated arthritis, we need to think a little bit beyond the box and beyond some of the points that I've highlighted today. I think in particular for these patients and these children and young people, we need to do additional planning. There needs to be coordination of multi-service, because we know children with Down syndrome may also have a requirement of other specialties like cardiology. There needs to be dedicated financing. I think there needs to be a coordinator for particularly identified. So one person who will coordinate all the specialties and link with the adult person in particular. I think it'd be nice to develop a local champion in our adult centres, so that we'd have one person in Cork or Limerick or Manorhamilton that in particular will see our children with Down syndrome arthritis early, and that will be involved in their care even from the early to mid stages of transition. We need to raise awareness, and I think we also need to work with electronic records. And many of you know that we're moving to the new hospital. You've probably heard we're going paperless. So we have an opportunity now to have a more seamless transition, because our adult colleagues will be able to view the patient records, and rather than depending on photocopying 400 pages and parents trying to get charts and records, the beauty of this electronic record system is that our colleagues on the other side, on the adult side, will be able to go back and see the history very clearly. Finally, I just want to highlight again, transition is not a once-off process, and it's not a transfer. It should never be considered a sprint, a back and pass, or simply the event of transfer. Transition is in reality a marathon, and once well done, can be very successful. So I want to thank you all, and I hope you all have a wonderful World Down Syndrome Day. I want to thank the parents and families especially, because without you, we couldn't do this work. And thank you for your continued support. And I'm going to pass now on to my colleague, our occupational therapist, Cathy White.
Thank you very much, Orla. I really appreciate that. That's Dr. Orla Kileen, consultant paediatric rheumatologist at the National Centre for Paediatric Rheumatology at CHI in Crumlin. So I'm delighted now to hand over to Cathy White, clinical specialist or occupational therapist in paediatric rheumatology at CHI in Crumlin. And while we're just waiting there, a few people just asked a question if this is being recorded. I know they joined late. So just to let you know that a link will be sent to the recording afterwards. And if you have any questions, if you can pop them into the Q&A section. Thank you.
Hi everyone. So myself and my colleague Rachel, we're going to talk a little bit about the patient journey when patients are referred to therapies at CHI Crumlin from the medical team. So we won't be just talking about OT and physio, but we'll mix it all together because a lot of patients do see both of us. So when a patient attends rheumatology clinics for initial or review, they might be referred to physio and or occupational therapy. And if we want to see them for a longer assessment, we book them in for a multidisciplinary appointment. We can also link back with their local teams across the country. So we're dealing with teams from 26 counties, and we're going to come on to that a little bit more as we go on. With a patient's consent, the other day we took a picture of what an appointment looks like with us. We, compared to the busy medical clinic in the outpatients department, when patients are referred to us, we have the luxury of time. So we have an opportunity to talk through any queries that they may have, especially if they've been newly diagnosed with Down syndrome associated arthritis. Often families have lots of questions, and we have the opportunity to go through the history with them again. And if there are any queries around medicine or anything, we can direct them to the team appropriately. So here it is. We have a big gym downstairs where we can see patients and their families and take our time to do a comprehensive assessment. This is what we ask about and assess. We recap on the medical history and look at how the arthritis presented. So as Dr. Kileen described, signs and symptoms can be so subtle and can be over quite a long period of time. And we're often looking for subtle loss of function that don't have an obvious alternative explanation. So again, we might have time to just dig a little bit deeper and trash through those things and decide, you know, are they things we need to look at? Are they areas of concern? Are they things that we want to monitor? Medication is really central in rheumatology practice. And the journey that the patients are on in regards to medication is really important. So they might be still taking steroids, which on a short-term basis might reduce inflammation. They might be due to start medication for their arthritis to stop the disease process, or they might have started medication and we might be checking in with them about how they're getting on and have they noticed an improvement or a difference in their function since then. So that will inform our practice and what we might do or suggest to those patients. We will look at how the impact or the diagnosis impacting their daily life and activities. And Rachel is going to go into the physical exam from a physiotherapy perspective, where they'll always conduct a full body assessment. And as an occupational therapist, we have particular interests in the upper limb. So we will look in more detail at the hands and the wrists. So as you mentioned before, we will link in with any local services, primary care or children's network disability teams that our patients are linked with. And we're aware that there's huge variation in the level of service provision across the country. But anywhere that we can, we will link and support because although awareness is growing, as we've discussed, often it can come as a surprise to families and can come as a surprise to their local therapy teams. So we can link in and give advice around that. So I'm going to hand over to Rachel now, and she's going to talk a little bit more in detail around the physiotherapy.
Hi everyone, I'm Rachel. I'm one of the physios working on the rheumatology team. So today I'm just going to talk you through what we do in physiotherapy for children with Down syndrome associated arthritis. So with the OT or in a physiotherapy session alone, we'll work through a subjective assessment, so going through a history. This is why we often join up with the OTs, as we can share out this history and save families having to repeat themselves. Then we'll do an objective, a physical exam, and we'll go through some treatment, which does consist of a lot of education and maybe some exercises. And we also have a huge role with these patients around steroid injections, as they often receive these to help manage their disease. So for our subjective assessment, we'll be going through all of these questions in detail. And there are some questions specific to arthritis in Down syndrome that we really want to hone in on to see how long this has been going on and how their function might have changed. We'll also go through their past medical history, what medicines they're on, how this is affecting the home life and their activities of daily living, how they're getting on with things that they enjoy doing, such as sport and leisure activities. Are their energy levels up or down? Has it impacted on their learning or school? And for the older child, we might touch on career planning and development for the future. We'll also kind of want to get an idea of what information they've been given to date and what their understanding of the condition is. And we do have time to kind of go through questions that families might forget in clinic or might come to them at a different time. We'll also ask about who they've been linked with in the community, if they have any occupational physiotherapy locally or any other professionals. And then we'll want to get an idea of what their goals are. So we do know that children with Down syndrome present with other musculoskeletal conditions, and we'll take this into account when we are prescribing exercises or education. So the big thing is hypermobility and how flexible these children can be. We know that they can have a lower muscle tone and they can have some differences in their motor milestones where they might be later to walking. Also pes planus, which is that hypermobility in their foot posture, flat feet, and sometimes scoliosis and C-spine issues can be there. So we will take all of these into account when we're working with them for physiotherapy. So our physical exam looks like a full joint assessment. So we'll go through the range of motion in every joint. As we examine, we'll be looking for which joints have swelling, pain, any restrictions, where are they very hypermobile, or is there any signs of old thickening? And to do this, we'll use a P-GALS assessment and goniometry, which is using a ruler to measure range. We'll also look at muscle length and strength testing. We'll have a look at their posture, how they're walking, and how they're functioning, moving around the room. This is just to give you an idea of the P-GALS assessment tool. So it's Paediatric Gait, Arms and Legs and Spine Assessment. And it's where we work through every single joint in the body. We'll get the patient to copy us doing most of these movements. So we really want to make sure that we're systematically working through top to bottom and we're not going to miss any single joint. We do this for every patient that sees us in the hospital. And then for our Down syndrome patients in particular, what we'll be looking for extra will be asymmetry in range of movement. So maybe they won't be able to tell us where there's pain, but we'll be looking out for, is there a difference in one side compared to the other? Is there any flinching when we move this joint to the end of its range? Is there any signs of joint swelling or old thickening? Any heat? And then at the end, we'll be looking at what their active joint count is. So what does our management look like? Well, there's a huge education role that we have to play here. We really want to talk to the families about a sign of if they had a flare of their disease and how we'd want them to manage that flare of their arthritis. We'll go through exercise therapy for any affected joints that do have arthritis active at the time. That might be some range of movement exercises, some passive exercises, or if we think it's appropriate, we'll get them working on some strength exercises to get the muscles as strong as we can to support those joints. Or maybe we're going to push them on to some cardiovascular exercise. We're going to be looking at their function overall. How do they manage their pain in a flare? We're going to be educating that family on what to do in a well-controlled disease versus a flare-up. So things like when their disease is well-controlled and they're well-established on medicines, we want them to be as active as possible. We want them to be involved in whatever sports and whatever activities they enjoy that's going to lead them to be physically active. So a lot of our patients will tell us they get great enjoyment out of clubs like Special Olympics or swimming or gymnastics. And we kind of say anything that you want to do that you enjoy that's going to keep you interested in that sport, that's the one that we want to encourage. We spend a lot of time liaising with local services and schools. Sometimes that might be a phone call or sending out home exercise programs to SNAs. And then we'll always modify that home exercise program for where the child's at. We're going to meet them where they're at for their age and their developmental ability. And often we'll just want to check that they have been linked in with their local services for orthotics, because as we know, these children often do have pes planus and they can really get benefit out of some orthotics. Just to give you an idea of what we might do for those children who are extra flexible, we want to get them as strong as we can. And sometimes that kind of has to be modified a bit for their hypermobility. So we'll be really working on strength exercises, and that might be a closed chain exercise, such as the bridge that you can see at the bottom here, where they don't have to control their joint in space. We'll also be spending a lot of time on education around building up that child's endurance and pacing. And often these would be the children who really struggle going for longer walks with their family, or they find it hard to go to the shops or get around the zoo. And sometimes we can make some goals around how we would try to slowly improve that. Core strengthening can be a really big part of this, but ideally they won't be doing a physio program very long term. We want to use the physio program to try and get them into that regular physical activity that's going to keep them interested and engaged, if that's swimming, cycling, gymnastics, whatever that is for them. And then for some of our children with arthritis who do have the stiff, restricted, painful joints, we want to try and keep them moving really gently to keep that range of motion. We might give them out some stretches. We're going to educate them on how to protect that joint during an active flare. So we normally would say to avoid maybe higher impact activities for a few weeks while that flare is ongoing. But as soon as they can, getting back into their normal activities, because we really, really want to try and keep the strength in the muscles that are protecting that joint, because we know that muscle loss is going to be really hard to get back after that flare. During a flare, they can experience some reduction in that range. We want to talk to them about keeping things moving, avoiding joint damage, pain management. Is there anything that works for them, like heat or ice pack, using their pain relief? We wanted to keep the muscles from getting wasted, trying to avoid any changes in their gait, and keep them in school and trying to keep them in their normal activities as much as possible. So hopefully our patients do get to a point where they have this well-controlled disease. And then in these periods of remission, sometimes we will advise to keep going with some certain targeted exercises. But overall, it's a chronic condition, and practicality of a long-term home exercise program, we know it's just not fair to families to burden them with a physio program that's going on for months and months. So we talk about taking a holiday from your physio, just getting back into your normal activities, and that's absolutely fine. We also play a role, like I mentioned, around intra-articular steroid injections. So a lot of our patients will attend here for injections to try and control their disease really rapidly. So we advise about 24 to 48 hours of rest afterwards. Sometimes we might have to splint if there is a really restricted joint. We understand it's not always an option for younger children, but we try to say avoid any vigorous play. And then we really encourage that early physio review with their local team after injection, just to try and get them started and really make the most of the steroid in that joint to try and strengthen up that joint. Now I'll hand it back over to Cathy.
Finally, I'm just going to go into a little bit more detail around occupational therapy. And firstly, I know a lot of people here will know of an occupational therapist or have met an occupational therapist and know what we do. But just to highlight that as occupational therapists, we're looking at occupations and in their broadest sense and supporting people to engage in those activities of daily living, no matter what the issue is for them. So it's a very, very varied role. And I've put in a few pictures of the kind of things OTs do, which are very different in different settings. So, you see there in the first one, what a lot of people might think of, making home adaptations or modifications for people that want to live independently. And then in that other one, how my colleagues primarily working in mental health might use occupation or activity as a therapy modality in itself. In pediatrics, we're really focused on the primary occupations of childhood, which most importantly is play, and also the big one is school. So if we can support around fine and gross motor development, or address sensory concerns, or suggest modifications or changes that might support children to engage with those occupations of childhood, then that's what we do. And across CHI, different, and across in all the, I'm so upset I'm muted. Across CHI, we work across all the lots of different medical specialities, but that is the unifying thing, is around childhood occupation and what children need and want to do in order to develop to their fullest potential. So obviously that looks so different with my colleagues working with tiny neonates on the neonatal unit, who are just getting used to life in this busy, noisy world. Right through to my colleague who sits beside me working in the complex pain team, supporting teenagers with a biopsychosocial model of care with that particular journey and the difficulties that they're experiencing. So it's hugely varied, but that it has occupation at its focus. So in Down syndrome associated arthritis, we have a big focus on fine motor and development in the upper limb, because we know from Dr. Kileen's research that there really is a predominance of involvement of the hands, the joints in the hands and the wrists. So pretty much for all our patients, we recommend a strengthening program that strengthens up the little tiny muscles inside the hands in order to support them to engage in all the activities that they want to do throughout the day. Often that will involve using therapy or something similar, something age appropriate, with a focus on their development. We look at their school and their activities and see if we can modify or give ideas to support any difficulties they might be having in that regard. We often link directly with schools who might have a lot of questions if they hear that the child that they're caring for has a diagnosis of arthritis. So we're more than happy to do that. And again, any local services that are involved, we might link with them. If there are specific programs that they're doing, they might want reassurance that they can continue with them, which is almost always a yes, because as Rachel was saying, we want to keep them as active and moving as possible. We occasionally use splints for children with DA, although not quite as commonly as we do with other children. Often they're not tolerated quite as well, and often they're not needed. So the one there at the front is a thermoplastic splint. They are custom made for children. That particular one is a resting hand splint. And the idea behind that is you're placing the hand and the wrist in a nice neutral position with the collateral ligaments stretched at their maximum, in the hope that when they come out of that splint, they will be much less stiff than they were before. Or if they're in a lot of pain during a flare, it's just generally considered a really good position to be in, because the hand is some of the joints are flexed and some are straight, so that there's not so much stiffness afterwards. Lots of patients that we meet find that really beneficial on a temporary basis when they have a lot of hand pain, and then others don't want them at all. So it's very much a case-by-case basis, and with some very minor exceptions, we wouldn't recommend particularly any children having to wear one splint or another, other than those where we could see that we want to preserve the range in a contracted joint. It's patient preference. That one behind there is an off-the-shelf splint. Some patients who might have a lot of wrist pain during function or activity get some benefit from those kind of things. But again, it's patient preference, and there's no one-size-fits-all. Just to highlight as well, as Rachel was saying, we have a developmental focus about the right level of therapy for this particular child. Every child that we meet with DA is very different in their strengths and their abilities. And we might meet a child in the morning whose aim is to maybe write their name or to get back to doing a little bit of colouring. And then you might meet a child in the afternoon who's the same age but has ambitions to go on and do their leaving cert. So we have the time and the capacity to get to know families. We know them for quite a number of years, and we can understand what therapy is at the right level for that particular child at that time and what might be better left for another time. So finally, we've all mentioned that we liaise directly with the CDNT and primary care teams where we can. We all know there are very varied levels of support available, and some are in special schools that might have a therapy team available to them, and then often those posts sadly aren't filled. So any support to staff that we do get in touch with, we can give, no problem. A lot of the therapists that we do liaise with are much more specialized in neurodevelopmental and not necessarily MSK, physio or occupational therapy. So we're always happy to be that link or to keep on that piece of work at CHI Crumlin. As Dr. Kileen mentioned, the lack of awareness of arthritis is thankfully improving, but again, still patients, families, educators, and primary care therapists are surprised by diagnosis. So often it is educating on a lot of the topics we covered today, and what to look out for, what could be a subtle sign for concern, how to contact us if they do have concerns. And thankfully, through lots of outreach and education work, we're getting much closer with our links with our community colleagues, and they are reaching out to us if they do have concerns or questions, which we're delighted about. So finally, with transition being the kind of the theme here, as well as therapy today, when we are seeing older teenagers nearing transition, our therapy really is much the same, but with just a different lens. We're looking at what the goals are and what are the family's goals. Unfortunately, we all know local services generally prioritize early intervention in younger children. So often they're no longer involved or soon will be discharging our patients. So we talk a lot around that and how we can support them going forward and through the transition process. And there are physios and OTs to varying levels available to refer on to in the adult hospitals. So that's everything from us. We're happy to take any questions. I know that Tara is going to moderate that for us, and we'll just move in so that each of us are available to take any of them. Thank you.
Thank you very much, Rachel, Cathy, and Orla. That was great. We have some questions for you, so we'll kick off with that if we can. Let's see. So I'll start off with a question here about what if Down's arthritis is suspected in an adult with Down syndrome, and are there many instances where Down's arthritis is only diagnosed in adulthood?
Yes. Do I take that, Tara?
Yes, please. Thank you.
Tara, you might say that again. We just lost the sound there for a few seconds. You might tell us that question
sorry.
again.
No problem. So the question is, what if Down's arthritis is suspected in an adult with Down syndrome? And are there many instances where Down's arthritis is only diagnosed in adulthood?
I think there will be more incidences because our adult colleagues are really only becoming aware of this. So I suspect there will be more cases identified because of our younger patients moving into the adult setting. So up to now, my adult colleagues would have been very unaware of this. So I suspect we will be seeing more diagnosed in adulthood because of that awareness. And when we meet twice a year at what we call the Irish Society of Rheumatology, we generally try to have something about DA, whether it's a poster or a presentation. So I know my adult colleagues are becoming more aware. Also, you have my Vincent's team who probably have great experience now because of patients filtering through, but we have also tight links with James's hospital. We have a new post between half James's, half here. So our colleagues who are filling this job showing that post are developing and upskilling in DA. So I think we're going to see more diagnosed. Now, other conditions, sometimes gout can be present as well. It's not just DA, but there is instances of gout in children, in adults with Down syndrome. So you always have to be thinking beyond the box. But up to now, there would be very few diagnosed in adulthood, as far as I am aware. But you'd have to put that question, of course, to an adult rheumatologist. But in general, my understanding is very few.
Okay, thank you, Orla. I'm not sure. I think this may be a question for Cathy and Rachel. It's great to hear about the Yard Clinic and transition to Mr. Malloy's clinic. Some Down syndrome patients have chronic swelling in their PIP joints. How do you differentiate this from synovitis inflammation, especially when clinical examination is sometimes limited and if there's long waiting lists for MRI imaging?
Yeah. So I think that's a clinical question again, Tara.
Okay.
So arthritis in juvenile arthritis, or JIA or DA, is a clinical diagnosis. So we go on all the normal things. It's a combination together, the clinical picture, sometimes blood, sometimes imaging. But our young people with DA are very prone to small joint involvement. They have a pattern that's actually very like psoriatic arthritis. So it loves the small joints of the toes and hands. So we have to go on clinical markers. But there's times that what we call chronic changes, because it's called what we call chronic bony thickening, will develop over time. And then you have to try and differentiate between bony thickening or swelling of the joints. And it can be hard sometimes. Sometimes you may not know, you might have to use ultrasound or imaging, but other times the clinical indicators are there, like we examine every other patient, looking for heat, swelling, tenderness.
Okay, thank you. And there was a question actually about old thickening and how that's observed, and if that was on X-ray. So I think that's what you just confirmed there, Orla.
Yeah, clinically you will see, you can appreciate some thickening of, but it's bone, because when you get inflammation, you get increased blood flow to the area. And with that blood flow, you get what we call growth factors, and you can increase bony turnover. So bone is bone. It's never going to go away once it's bone. But I mean, it's more cosmetic. It's not that it causes a functional problem. So bone looks thickened, but on X-ray, can you see thickening of bone? You can sometimes, definitely, yeah. You'll see bone and thickening on X-ray.
Okay. This is a question for Cathy. Do you ever recommend lycra garments or compression garments for wrists and hands for those with Down syndrome arthritis? And if so, are there any particular ones that you recommend?
So there's no clinical evidence for the use of, like, I guess that's like isotoner gloves and similar compression garments to those. Lots of people use them. Lots of people use them anecdotally to good effect. And all the time I've been working in rheumatology, people have reported benefit from them and without any massive side effects. So I think if any of us imagine a time where we've hurt or injured a joint, like we've sprained our ankle or we've hurt our wrist, and you bandage it up nice and tightly, it's very supportive, and it provides, you know, it protects the area a little bit, so it's no harm at all if they want to try it, but there isn't a lot of evidence to back it up.
Okay, all right, thank you. There's a question here from a health professional. I think it's, I work in a CDNT. If I have a concern about DA, what is the referral process?
Well, it's the same for any patient. We would recommend that the patient would get a clinical referral letter. So it would be best, so we get the full clinical history, that the patient attends their GP or pediatrician, and write it to us with all the details. And often if a patient has come via physio or an OT route, the GP would usually enclose the physio and the OT's concerns and reports. That would be the most helpful way of doing it. Yeah.
Okay. Okay. We have another question here. Sometimes we hear of neurotypical children with arthritis who may be admitted for a week or two for intensive MDT input or hydrotherapy. This doesn't seem to apply to our cohort of children with DA, and is there a reason for this?
Well, we don't have a dedicated inpatient rehab program, unfortunately. So most patients that come as inpatients are somebody who's got an acute diagnosis, might have 40, 50 swollen joints. So that would be the most likely inpatient. We're very much an ambulatory service. And anybody with chronic pain, we've probably moved away from inpatient stays as much. We've tried to do things as much as an outpatient, so that the patient doesn't end up being too reliant on an inpatient stay. So it's rare actually for us to do inpatient stays anymore, but we'll always be directed on the clinical need. And the most likely reason for an inpatient stay would be a bad flare or a new patient.
And DA patients wouldn't be excluded from that.
Absolutely not, if they needed it, yeah.
Okay, all right. We do have a question here. What if the person with Down syndrome cannot have an MRI due to a pacemaker?
Yeah, that is a problem. But I am told that some of the newer models are actually pacemaker compatible. So I think we will hopefully have one of those in the new hospital. But the current machine, as far as I understand, is not compatible with most of the types of pacemakers. But also, I believe my cardiology colleagues have told me the newer pacemakers are compatible. It's not actually that the MRI machine needs to be compatible. So I think it's going to be more that the pacemakers will quicker be compatible, but it's something that's coming and it is available in some places.
Okay, okay. We have another question here about a 5-year-old who is taking nifedipine, and it has been life-changing for her. But the question is about dietary, you know, and nutrition. Is there any recommendations for food that you should eat or avoid, or would you recommend they link in with a dietitian or a nutritionist?
Well, we're very much an evidence-based specialty, as we recommend all medical specialties to be. There's no research to say that any particular food group is of benefit. There's been some small studies looking at fish oils in adults, and it's shown to be slightly beneficial in rheumatoid arthritis in adults. Unfortunately, there's been no studies replicated in JIA, and there's certainly no studies in DA that I'd be aware of. So our general advice is a good, healthy, balanced diet. That's what we would say to anybody with a chronic illness.
Okay. Can children with confirmed Down syndrome arthritis from a private clinic get access to CHI, physio and OT, even if it's to get an assessment and plan from their local team that they can implement?
Yes, that's always been the case. We're very fortunate with the setup here that we have access and any input that's needed, you know, from our team, for either physio, OT, and the wider MDT at times. Yeah.
Okay. There's a question here about screening tools that are used to diagnose in childhood, and if not, would you use predisposing factors such as hypermobility as indicators? I think that question's kind of been answered, has it already?
But hypermobility isn't a risk factor for arthritis. Is that what the question is? For inflammatory arthritis, it's not.
Yeah, so it says, what screening tools are generally used to diagnose it in childhood? If not, would you use predisposing factors such as hypermobility as indicators?
So there's no specific screening tool for DA, but there is, the team here have made a leaflet outlining some of the potential symptoms that Dr. Kileen has gone through, and that's available on the CHI website, as far as I know, but we can send it as well.
And it's on the
I think it's on Arthritis Ireland website too.
Okay, thank you. Do children with Down syndrome arthritis have actual periods of remission, or do they tend to be more active for longer periods than other types of arthritis? This is a question from a health professional. They have a client on their caseload who appears to have little or no remission.
Yeah, good question. So I'll just allude back to my few slides I put up there. We know it's a more aggressive type of arthritis, definitely. And, you know, time will tell because we just don't have any long-term data yet. But our clinical, and this is anecdotal, is that really we don't see as much remission in DA as we do in JIA. So we do know it's a rockier course, definitely.
Okay. And there's a question here about biologics. So I think the question is about, is there like a lot of weight gain with the biologics, and then does that have an impact on movement and making, you know, improving movement in children with Down syndrome arthritis? So
there is no weight gain isn't a side effect of biologics. You probably might be thinking of maybe of corticosteroids.
Yeah.
So steroids certainly can cause weight gain, but thankfully we don't have to use much steroids either in juvenile arthritis or JA or DA, because we have, you know, options of other medications, biologics, and obviously biologics and methotrexate in JIA. We avoid methotrexate in Down syndrome associated arthritis because we know that our young people and children with DA are much sicker on it. So we're fortunate enough that we have very good access in Ireland to biologics, and we're able to go straight onto a biologic as a first line rather than having to fail methotrexate. But thankfully, weight gain isn't a known well-known or established side effect of any of the biologics. It'd be more a side effect of corticosteroids or prednisolone. Okay, great. I think that's more or less the questions that we have at the moment. Let's see. Yeah, I think that's more or less all of the questions. I'm not seeing anything new coming through. Just some thank yous from some of the people who attended the webinar, just to say thank you so much for your time today and for a really insightful webinar. I think it's been very beneficial.
So that just leaves us to say thank you again to our three presenters today, our speakers. We really do appreciate your time. We know that you're very busy. And I'm going to hand over now to Aisling, because I know Aisling has a video that she would like to play that was created by the parent support group Down with Arthritis. So thank you everyone for your participation and your time and all of your questions.
Hi, thank you very much, Orla, Cathy and Rachel, and again to Arthritis Ireland for hosting this webinar. We really appreciate it, and hopefully we will be able to do it maybe next year or again about maybe different topics. It was very informative. Thank you.
Thank you very much, Aisling. That was lovely, and we really appreciate you putting that together. So I think we're going to leave it at that. Thanks again to everyone for attending. And like we said, the webinar has been recorded, so you should receive a link to the recording tomorrow. And we'll also have it available on our YouTube channels for anyone else who wants to catch up and watch it another time. Thanks again.
Thank you.
Thanks, everyone. Take care. Bye-bye.